The pituitary gland is one of the true endocrine glands. As we've mentioned before, the posterior pituitary stores the neurohormones that are made by the hypothalamus. Now, these substances are neuro in the fact that they are produced by a nerve cell and stored in the axon, but their hormone quality is that when they are released from the axon, they're picked up by the blood and they're carried to their target cells in the blood. The two hormones stored in the posterior pituitary are oxytocin and antidiuretic hormone, or ADH. Both of these hormones are composed of just 9 amino acids, and they're very similar in structure, and yet they have very different functions. Oxytocin stimulates uterine contraction and milk ejection, not milk production, but the milk released from the breast. Oxytocin is one of the few things in the body that relies on positive feedback. A positive feedback system occurs when the stimulus causes something to happen that continues to increase the stimulus. In the case of oxytocin, the stretch of the uterine muscle stimulates the release of oxytocin. Also, during pregnancy, oxytocin receptors are uploaded on the uterine muscle so that at some point between the stretch of the uterine muscle and the increased number of receptors, the uterine muscles begin to contract. Now, when they contract, they get shorter. But the baby is still in the uterus and it's still pushing on those muscles, so the muscles actually feel like they're even more stretched, so more oxytocin is released. And this keeps going on until the uterine contractions are strong enough to push the baby out of the uterus. Now, once the baby is gone, there's no more stretching of those muscles, and that's what shuts down the positive feedback system so that oxytocin stops being produced. Oxytocin is one of those things that can act as a neurotransmitter in the brain. In males and non-pregnant females, it's sometimes called the cuddle hormone. It's involved in sexual and affectionate behavior, and it promotes nurturing, couple bonding, and trust. So when couples are not intimate and they don't have a lot of oxytocin produced, they may not feel as close as a couple that does have a lot of affectionate behavior and high levels of oxytocin. Antidiuretic hormone does exactly what its name says it does. It inhibits urine production. Diuresis is urine production, so anti against diuresis, antidiuretic hormone. Osmoreceptors in the hypothalamus are what monitor the solute concentrations in your blood. And if those solute concentrations get a little too high, antidiuretic hormone is produced, and antidiuretic hormone targets the kidney distal tubule cells to reabsorb more water. That water goes back into the bloodstream, essentially diluting your blood. When your blood gets more dilute, when those solute levels fall, antidiuretic hormone stops being produced. So this is a negative feedback system based strictly on the concentration of materials in your blood. Antidiuretic hormone does have some alternate pathways for triggering. Extreme pain may trigger it, low blood pressure may trigger it, and certain drugs like nicotine, morphine, and barbiturates. Low blood pressure is one of the things that triggers it because if you have a low blood pressure, you may have a low blood volume. And so antidiuretic hormone will help pull water back into the blood, increasing your blood volume and increasing your blood pressure. Interestingly enough, another drug that inhibits ADH secretion is alcohol. And this may help explain why if you're out drinking with your buddies and you're consuming a lot of alcohol, you tend to spend a lot of time in the bathroom eliminating that alcohol. You're not really eliminating the alcohol, but you're eliminating water from your body. You're actually concentrating the fluids in your body at the expense of water. Water is going out. A hangover is largely the result of dehydration. So if you can remember to drink water through the night, you may avoid that hangover the next morning. Antidiuretic hormone is sometimes referred to as vasopressin. There are some receptors on the smooth muscle of blood vessels. In times of extreme blood loss, antidiuretic hormone can act to cause the smooth muscle of the blood vessel to contract and thus help keep your blood pressure up. Antidiuretic hormone may be secreted in too limited a quantity. When that happens, it's called diabetes insipidus. If you're not secreting antidiuretic hormone, you never conserve water. Water just goes out of your system. And that leads to polyuria, excessive urination, and because so much water is leaving your body, you're thirsty all the time. And that gives you polydipsia, excessive drinking. As long as the problem is truly a hyposecretion of ADH, it can be treated. You can be given antidiuretic hormone and that will take care of the problem. Sometimes, however, diabetes insipidus is the result of a receptor problem on the kidney tubules. That cannot be treated. If your antidiuretic hormone level is normal, but it's the receptors that are abnormal, we can't really treat that problem. Hypersecretion of antidiuretic hormone is called syndrome of inappropriate ADH secretion. Because now you're retaining fluid all the time, the problem is brain edema and weight gain, brain edema in particular. This is usually the result of a tumor. Once the tumor is located and destroyed, everything goes back to normal. But in the meantime, the brain edema is the thing that can kill. The anterior pituitary secretes its own hormones. It is under the control of the hypothalamus. The hormones secreted by the anterior pituitary are growth hormone, thyroid-stimulating hormone, adrenocorticotropic hormone, follicle-stimulating hormone, luteinizing hormone, and prolactin. Growth hormone, sometimes referred to as somatotropin, stimulates the growth of all cells, particularly the bone and skeletal muscle cells, because that is what has to grow the most when people are growing taller. The release is regulated by the hypothalamus through that growth hormone releasing hormone that then tells the anterior pituitary to release growth hormone. There is some evidence that a fairly new hormone that's been found that has to do with how you use food, a hormone named ghrelin, may also be involved in stimulating growth hormone. If growth hormone is oversecreted, and this occurs in children, children grow abnormally tall, a condition called giantism. If the growth hormone oversecretion occurs after people are adults, there are very few bones that can be stimulated to grow. It's a condition called acromegaly. The bones of the hands and the feet can still grow, the jawbone and the frontal bone can grow. So these people get extremely large hands and feet and get a misshapen face because their jaw juts out and their forehead starts to overgrow. Hyposecretion leads to a condition in children known as dwarfism. Here you see a picture of a pituitary giant, a pituitary dwarf, and a normal person. Notice how everybody's pretty normally proportioned here. Dwarfs typically only get to be about 4 feet tall or so. Giants can be 7 to 8 feet tall, and this woman is probably about 5 feet tall. So there's quite a bit of difference in that, and that's just simply the result of growth hormone. Thyroid-Stimulating Hormone, or TSH, is also known as thyrotropin. TSH stimulates normal growth of the thyroid gland as well as stimulating the function of the thyroid gland to secrete its hormones. This one is regulated by the hypothalamus using thyrotropin releasing hormone. Adrenocorticotropic hormone, or ACTH, is sometimes known as corticotropin. I'm only telling you this because it's going to make a little sense later on. Adrenocorticotropic hormone is actually split from one big molecule called a prohormone, pro-opiomelanocortin, POMC. This big prohormone is broken down to give you ACTH, 2 natural opiates, an enkephalin and an endorphin, and a hormone known as melanocyte-stimulating hormone. Now you might think that this would stimulate melanocytes to produce pigment, but it doesn't really do that. The role of MSH in humans is not clear. We're beginning to think it might be involved in appetite control, and certainly high levels of MSH may cause some skin discoloration, but for the most part, we just don't really know what this one does. ACTH stimulates the adrenal cortex, a part of the adrenal gland. It too is regulated by the hypothalamus through corticotropin releasing hormone. The gonadotropins are FSH and LH. FSH, or follicle-stimulating hormone, stimulates the ovaries and the testes to produce gametes, eggs and sperm. Luteinizing hormone, or LH, promotes the production of the hormones that are produced by the ovaries and the testes, estrogen, progesterone, and testosterone. Gonadotropin-releasing hormone from the hypothalamus is what stimulates the production of FSH and LH. Prolactin is the hormone that stimulates milk production. Prolactin is primarily controlled by prolactin-inhibiting hormone. Now, prolactin inhibiting hormone is another one of those hormones that has the same chemical structure as a neurotransmitter. It has the same chemical structure as dopamine. Now, men tend to produce a lot of dopamine naturally, so they have a lot of this prolactin inhibiting hormone, and non-pregnant women tend to produce a fair amount of dopamine. As estrogen levels climb, and this happens during pregnancy, prolactin release is increased, so that estrogen levels affect prolactin. Now, some women, because estrogen levels rise during the menstrual cycle, experience a little soreness in their breasts at certain times during their monthly cycle, and this is the effects of estrogen stimulating a little bit of prolactin release. The breasts are a little bit stimulated, but it takes high estrogen levels of pregnancy typically to cause milk production. An excess of prolactin in the blood, hyperprolactinemia, is the most frequent abnormality seen with anterior pituitary tumors. Patients present with inappropriate lactation. They're lactating and they haven't had a baby. Their menstrual cycle has stopped and they are infertile. Hyposecretion, the other side of this, is only a problem if it's in a woman and she chooses to nurse or breastfeed. The thyroid gland secretes two different kinds of hormones. Thyroxine and triiodothyronine, or T4 and T3, are the hormones that stimulate metabolism. Again, these are regulated through the hypothalamus. Then there's another group of cells in the thyroid gland that secrete a hormone known as calcitonin. Calcitonin is secreted in response to rising calcium levels. Thyroid problems can be rather challenging to diagnose because there are a number of hormones involved in this process. The hypothalamus kicks off by secreting thyrotropin-releasing hormone. This stimulates the anterior pituitary to secrete thyroid-stimulating hormone, which then tells the thyroid gland to secrete the thyroid hormones T3 and T4. T3 and T4 target all of the cells in the body, and so these cells then use the T3 and the T4 to drive their metabolism. The levels of T3 and T4 in the blood also feed back, this is a negative feedback loop, to the hypothalamus and the anterior pituitary. If the levels are high enough, thyrotropin-releasing hormone and TSH production stops. The thyroid is no longer stimulated to produce T3 and T4, and the thyroid hormone levels drop. If they drop too low, that feeds back to the hypothalamus and the anterior pituitary. These hormones are released and we begin producing thyroid hormones again. There are several places where this can get broken. You could have an inappropriate secretion of TRH, an inappropriate secretion of TSH, or a problem with thyroid gland secreting the appropriate amount of thyroid hormone. If we look at the thyroid gland, we have two sets of cells here. We have these cells that are surrounding these smooth globules. These globules are called colloid. The production of the T3 and T4 is a multi-step process. In order for the body to be very responsive to the needs for T3 and T4, the thyroid gland actually takes the process of making the hormone almost to the end, and it stores the precursor hormone in the colloid. As soon as TSH stimulates these follicular cells, these cells around the colloid, the last couple of steps are taken so that T3 and T4 is released pretty quickly into the bloodstream. The other cells, the cells in between the follicles, are called the parafollicular cells or the C cells. These are the cells that secrete the other hormone produced by the thyroid gland, calcitonin. Hypothyroidism, or an underproduction of thyroid hormones, if it occurs in an adult, occurs a condition known as myxedema. Because the metabolism is decreased, they're very slow, they're very sluggish, they're very lethargic, they gain weight easily. There's a sort of edema under the skin that's almost like a thick, mucousy kind of fluid, not true edema. If hypothyroidism occurs in children, there are two possible causes. One is an iodine insufficiency. T3 and T4 rely heavily on iodine. It's the only organ in the body that really uses iodine, is the thyroid gland. So if there's an iodine deficiency, there's not enough iodine to produce T3 and T4, that condition is called cretinism. If children are truly born with a congenital problem of the thyroid gland, then it's called congenital hypothyroidism. In both cases, mental retardation results because the brain does not get enough energy to grow properly. The muscles and the bones don't grow properly, so these children tend to be malformed dwarfs. It's a real easy fix, just give them thyroid hormone. It is such an easy fix that children in this country are tested for thyroid hormone in the first few days of life so that they can be started immediately on thyroid hormone if this is the problem. Endemic goiter used to be seen a lot more frequently in this country. In this country, our best source of iodine used to be seafood, so people who lived on the shore had no problem getting adequate amounts of iodine. But prior to the ability to deliver seafood, either by freezing it or refrigerated trucks, people in the interior part of the country had a difficult time getting enough iodine. Because there wouldn't be enough iodine, there wouldn't be T3 and T4. The hypothalamus and the anterior pituitary would continue to produce their stimulating hormones. This would stimulate the thyroid gland to grow since it couldn't do anything else. It would either grow or have to produce hormones. It couldn't produce hormones. So this iodine insufficiency would lead to an overgrowth of the thyroid gland, and you'd have this lump on the neck. Usually they surgically remove the thyroid. It does have the effect of making people hypothyroid, and so they have to take Synthroid the rest of their life, or artificial thyroid hormones, but it does take care of the problem. Hyperthyroidism has many causes, but the most common hyperthyroid condition is Graves' disease. Graves' disease is an autoimmune disease. In this case, the body produces an antibody that looks so much like TSH that it stimulates the thyroid gland to produce T3 and T4. But this is a substance that's outside of the feedback loop, so it's constantly stimulating the thyroid gland to produce T3 and T4. This, of course, increases the metabolism of the individual. They're nervous, they have tachycardia, they lose weight like everything, and they have an interesting condition called exophthalmos, which is one of the dead giveaways for Graves' disease. It looks like their eyes are literally going to pop out of their head. Calcitonin is the other hormone produced by the thyroid gland. Calcitonin does not have a known physiological role at this time, but at pharmacological levels it can have bone-sparing effects. It's used to treat patients with Paget's disease and osteoporosis. Calcitonin will inhibit osteoclast activity and increase calcium uptake by the bone and osteoblast activity, making this an ideal substance to treat bone diseases. The parathyroid glands produce parathyroid hormone, or PTH. Parathyroid hormone acts to increase blood calcium levels. Calcitonin takes calcium out of the blood and puts it in the bone. Parathyroid hormone does just the opposite. So parathyroid hormone stimulates osteoclast activity. Your bones are your biggest reservoir for calcium in your body, and you must maintain a certain level of calcium in your blood for blood clotting, healthy muscle contraction, and nerve activity. Parathyroid hormone will also enhance the reabsorption of calcium from the urine by the kidneys and will increase calcium absorption from the intestine. We look at how blood calcium works. If blood calcium drops too low, that is what causes parathyroid hormone to be released, and it acts to break calcium out of the bone, reabsorb calcium from the urine, and by activating vitamin D, it will increase calcium absorption from the food in the small intestines. All of this goes to increase calcium in the blood. Now, once blood calcium levels get high enough, parathyroid hormone is turned off. If the parathyroid is overactive and produces too much parathyroid hormone, that osteoclast activity increases. This means that calcium is taken from the bone and big holes are left in the bone which fill in with fibrous tissue. This is a condition known as osteitis fibrosa cystica. Because of the high calcium levels in the blood, you will have depression of the nervous system, and that extra calcium will be eliminated through the kidneys, so there's an increase in the formation of kidney stones. With hypoparathyroidism, blood calcium levels may fall too drastically. This causes nervous tissue and muscle tissue to be hyperexcitable. If muscle tissue is hyperexcitable, it's going to contract. This is a condition called tetany, And one of the things that can happen is you have a lot of tiny, tiny little muscles in your larynx. If they all contract at one time, you have something called laryngospasm, and this can actually close off your airway. So this can be life-threatening. The adrenal gland is like two separate glands. We have the adrenal cortex and we have the adrenal medulla. The adrenal cortex secretes a group of hormones that are known as the corticosteroids, and there are three basic corticosteroids. We have the mineralocorticoids that are involved in mineral and water balance. We have the glucocorticoids, which are involved in glucose metabolism and in helping combat stress. And then we have the Gonadocorticoids, which basically increase masculinization. There are several different mineralocorticoids, and they're all involved in regulating electrolyte concentrations in the extracellular fluid. The major mineralocorticoid is aldosterone. Now, aldosterone acts to reabsorb sodium in the kidney. As a result, several other ions and water are also regulated. If you're saving back positive ions like sodium, you have to get rid of some other positive ions like potassium and hydrogen ions. You also have to save back a certain number of negative ions to balance those positive sodium ions. So you've got chloride and bicarbonate saving. And water always follows sodium. So if you're saving sodium, you're saving water. The mineralocorticoids are very important in regulation of blood pressure and blood volume. Again, if you're saving sodium, you're saving water. Water goes into your blood, increasing your blood volume. As your blood volume goes up, your blood pressure goes up. Aldosterone is primarily regulated by blood volume, a decrease in blood volume, a decrease in blood pressure, and an increase in potassium ions can also stimulate the release of aldosterone, since potassium is indirectly controlled by sodium saving. With hyperaldosteronism, too much aldosterone secretion, you're going to get hypertension and edema, because hyperaldosteronism, you'll save back more sodium than you need, which means more water will follow, increasing blood volume, giving you hypertension, and that extra water, some of it will end up in your tissues, giving you edema. Because you're saving sodium, you're going to be losing potassium. And as potassium levels fall, your nervous system gets depressed and it's not as active as it should be, and your muscles don't contract the way they should, so you have muscle weakness. The glucocorticoids are things like cortisol, cortisone, and corticosterone. These hormones are essential to life because you must have these hormones in order to manage stress. They're regulated through the hypothalamus. You've got corticotropin releasing hormone from the hypothalamus, which stimulates the anterior pituitary to manufacture and release adrenocorticotropic hormone. The primary effects of the glucocorticoids, they stimulate gluconeogenesis. Gluconeogenesis, you will remember, is the formation of new glucose from a non-carbohydrate source, typically a protein source. In times of stress, you want to make sure that there's enough glucose for your brain. Your brain has to have glucose that can get to it directly, and so in order to keep your glucose up, what we call glucose sparing effects, you will turn to other sources of nutrition like the proteins to maintain your glucose levels. If you have an excess of cortisol for too long a period of time, one of the things it does is it depresses cartilage and bone formation. You're probably familiar with giving cortisol as an anti-inflammatory, maybe for a rash, a hydrocortisone cream you put on a rash to calm it down. The anti-inflammatory process here depresses the immune system. High levels of cortisol for long periods of time can make you more susceptible to disease because you're depressing your immune system. Also, your cardiovascular, neural, and gastrointestinal systems are disrupted as a result of the change in your metabolism. Cortisol is used therapeutically to treat chronic inflammation, things like rheumatoid arthritis or severe allergic responses. If it's used for too long, or if you have some reason why you're producing excess cortisol, there are some effects. First of all, there's a persistent hyperglycemia. All that gluconeogenesis keeps your blood glucose levels up. Because you're typically going and using protein, you have protein loss, you're taking protein from your protein stores. Your protein is primarily stored in your muscles, so you will see muscle wasting. It's rare for you to have just the glucocorticoids affected without also having the mineralocorticoids affected. So water and salt retention occurs, and there's edema and hypertension. And after a while, you get what are called the Cushingoid signs: a moon face, a buffalo hump, and little bird legs. The moon gets very, very round, and the features kind of mush in, so it really does look like you're looking at the moon. Because part of what the glucocorticoids do is they rearrange fat in your body. They distribute some of the fat onto your back, giving you the buffalo hump. And one of the first places you see muscle wasting is in the muscles of the legs, and that's why you get the little bird legs. Now this is the same woman. You notice the little fat hump here, the buffalo hump. You don't see the effects of the moon face because you're seeing her in profile, but you can see how she's lost definition of her jawline as a result of the edema in her face. And of course we're not seeing her legs, so we can't see the little bird legs that she also has. Addison's disease is an adrenal cortex hyposecretion. As a result, you have decreased sodium levels and decreased glucose levels. Because you're losing sodium, you're retaining potassium, so you have increased potassium levels. This leads to severe dehydration and hypotension. This disease is usually fatal. President Kennedy had Addison's disease, something that was kept from the population at the time. No one knew he had Addison's disease. It's only after his death that this came out. He probably should not have lived long enough to be assassinated. Now, there was always something about the Kennedys, particularly John Kennedy. He always looked incredibly healthy with that wonderful tan, but if you looked very closely at his tan, it looked a little bit artificial. Do you remember me telling you about that big pro-hormone that ACTH comes from? Something that broke off of that big pro-hormone was melanocyte-stimulating hormone. And while melanocyte-stimulating hormone doesn't have a normal role in the body, someone with Addison's disease would have high levels of that, and it causes an odd coppery pigmentation in the skin. Old-time doctors, before there were all the lab tests that they rely on today, could look at someone with Addison's disease and diagnose them simply by their skin color. The gonadocorticoids are androgens, or male hormones. We believe that they contribute to the onset of puberty and the secondary sex characteristics, the growth of axillary hair and pubic hair and facial hair in males. Hypersecretion in males is not much of a problem. It causes masculinization or virilization, and in males it may bring on early puberty. They may be a little sexually precocious. But in females it causes androgenital syndrome. This is the condition that the bearded lady at the fair has, the woman with the facial hair and the deep voice, because of the extra male hormones circulating in her body. Adrenal medulla is the other part of the adrenal gland. This part of the gland secretes catecholamines, and the catecholamines are epinephrine and norepinephrine. You'll remember that the sympathetic nervous system uses norepinephrine as the neurotransmitter. So these hormones, epinephrine and norepinephrine, have sympathomimetic effects. That is, they sustain the reactions started by the sympathetic nervous system. The adrenal medulla is stimulated by the sympathetic nervous system. So that fight or flight mechanism, whenever that's activated through the sympathetic nervous system, the nervous system is short acting. It gives you just enough of a jolt to jam on the brakes, maybe if you're about to hit a car. But if you need any other additional activities going on in the body, the adrenal medulla has to kick in with the epinephrine and norepinephrine to sustain that. You've heard of people who were in car accidents and were able to lift cars off of loved ones because of super strength. That was the adrenal medulla talking. A pheochromocytoma is a tumor that secretes catecholamines. Problem with this tumor is there is no control on it. It will suddenly secrete huge amounts of catecholamines. So for no good reason, all of a sudden someone's heart will be racing, they'll be sweating, they'll feel anxious, they'll have an anxiety attack, and this can really get the heart rate up to something like 200 beats per minute. Once your heart's going that fast, a heart attack or the increased blood pressure could lead to a ruptured blood vessel, neither of which is very compatible with life. Pheochromocytomas are sometimes in the adrenal medulla, but they can be anywhere in the body, and they can be extremely small, no bigger than your little fingernail. There have been some athletes who died rather suddenly, sometimes even in their sleep. They were initially looked at to see if perhaps they had died of a drug overdose. Autopsy frequently reveals that they had an undiagnosed pheochromocytoma, and it was the massive, uncontrolled sympathetic response that ultimately killed them. The pineal gland is the little tiny gland that's in the roof of the third ventricle in the hypothalamus. It secretes the hormone melatonin. We don't know a lot about melatonin, but it does seem to have a diurnal rhythm. It goes up at night and down in the daytime, and we believe it plays a role in our biological clock. Some people take melatonin at night to help them sleep. Some people take melatonin if they travel across several time zones to try to reset their biological clock. This works for some people. Other people it doesn't seem to work as well for. The pancreas is one of those glands that's not a true endocrine gland, but it has a major endocrine function. It secretes two hormones, insulin, which is involved in reducing blood glucose, and glucagon, which is involved in increasing blood glucose. These two hormones are antagonistic to each other, and they're regulated by blood glucose levels. Glucagon acts by increasing glycogenolysis, that is the breakdown of glycogen into glucose, and the increase of gluconeogenesis, which is the formation of new glucose from non-carbohydrate substances like proteins. Both of these occur in the liver, so it increases the release of glucose from the liver. Glucagon, because it increases blood glucose, is said to be a hyperglycemic hormone. Insulin reverses this process. It enhances glucose transport into the cells, and it's got to get into the cells so it can be used to make energy. Insulin is not needed for glucose to move into the cells of the liver, the kidney, or the brain, so that even if insulin levels are low, those tissues can still get glucose as long as there's an adequate level of glucose in the blood. Insulin will decrease glycogenolysis so that more glucose is stored as glycogen, and it will decrease gluconeogenesis so that you're not breaking down proteins to make glucose. Because it lowers blood sugar, it's referred to as a hypoglycemic hormone. Here you see the balance between the two hormones. We want to keep a normal blood glucose at about 90 to 100 milligrams per milliliter. If blood glucose levels go up, the pancreas secretes insulin so that glucose is taken up by the cells, but also the insulin encourages glucose to be converted to glycogen in the liver. The blood glucose levels fall back to a normal range. Insulin still continues to act and may take the blood glucose down a little too low. In that instance, some different cells in the pancreas kick in, release glucagon, and we break down glycogen in the liver. We increase gluconeogenesis, and glucose goes back into the bloodstream. We balance. Again, we probably overbalance up, and insulin takes over. So we manage to maintain a fairly normal blood glucose level throughout the day because of this antagonism between insulin and glucagon. Diabetes mellitus occurs when there is a hyposecretion of insulin or a hypoactivity of insulin. There is some evidence that insulin receptors may lose their affinity for insulin, and that can give you diabetes mellitus as well. Glucose can't move into the cell. There can be plenty of glucose in the blood, but it can't get into the cell, so the cells are starved. In order to produce ATP, the cells begin to use fatty acids. Now, when cells break down fatty acids, they make ketones, and ketones are acidic, so diabetics sometimes have a condition called ketoacidosis. Because there is excessive glucose in the blood, the glucose will spill into the urine, and you will see glycosuria. Because of the glucose in the urine, extra water is taken out of the body to keep the glucose soluble, so there's polyuria, excessive urination. You're losing water, so you're thirsty, that's the polydipsia, and even though there's all that glucose, your cells are starving, and they're sending out all of these chemical signals that say, you're hungry, and so there's polyphagia, excessive eating. Type 1 diabetes mellitus is sometimes called insulin dependent. And it used to be called juvenile onset because typically it occurred in younger people. It appears to be an autoimmune disease where the antibodies attack the cells of the pancreas that make insulin and destroy them. This means that these people have to take insulin. Because there typically is an early onset, type 1 diabetics are the ones that are most likely to have the long-term effects of diabetes, the vascular damage, and the neural problems. Type 2 diabetes is sometimes referred to as non-insulin dependent and used to be called mature onset diabetes. This appears to be more a problem where there are non-responsive receptors. Sometimes we talk about someone being insulin resistant. Now, there are the same medical complications as type 1. The longer you have this, the more likely you are to have effects on the cardiovascular system and the nervous system. There appears to be a hereditary predisposition for this, and lifestyle plays a role. Almost all type 2 diabetics are overweight. Typically, at least initially, you can control type 2 with diet and exercise. As the disease progresses, you may start to have to use other medications, and eventually you use insulin. Unfortunately, we're seeing an increase in type 2 diabetes in children, possibly because of the weight problem. Hyperinsulin, or an overproduction of insulin, causes hypoglycemia. Now, as your blood sugar falls, you become anxious and nervous. There are tremors and weakness. This is because there's not enough glucose in the blood to keep your brain happy. So your brain starts to shut down. People are disoriented, they may have convulsions, they may lose consciousness and even die. Very, very rarely is this condition caused by a pancreatic tumor. The most common cause for hyperinsulinism is an overdose of insulin. Somebody takes their insulin too soon before they eat, and as a result their blood sugar plummets. The gonads and the placenta also are organs that have dual function. They do produce hormones, but they have other functions as well. The ovaries produce estrogen and progesterone. These hormones are important to the development and maintenance of the female reproductive system. The testes produce testosterone. This hormone is important to the development and maintenance of the male reproductive system. The placenta is only a temporary organ present only during pregnancy, but it secretes estrogens, progesterones, and human chorionic gonadotropin, or HCG. And these hormones help with the maintenance of the pregnancy. We'll talk much more about these hormones when we do the reproductive system. Other hormone-producing organs include things like adipose tissue. We've discovered that the adipose tissue produces leptin and resistin and adiponectin. These hormones seem to be involved in how your body holds on to fat, stores fat, and even has something to do with appetite. In the gastrointestinal tract, there are any number of enteroendocrine cells that help control when secretions of various enzymes occur. The heart produces a hormone called atrial natriuretic peptide, and this is actually the antagonist to aldosterone. The kidneys secrete erythropoietin. Erythropoietin stimulates the bone marrow to produce red cells. Sometimes individuals who are on dialysis have a problem with anemia because the kidneys are not producing an adequate amount of erythropoietin. You can take this artificially. The skeleton produces osteocalcin, something that helps deposit calcium in the skeletal system. The skin produces calciferol, which is a precursor to vitamin D. And the thymus, while we talked about that as an endocrine gland, is part of the immune system. And it's becoming less and less clear how the thymus functions, but it produces thymopoietins and thymosins, and we believe that this is involved in the early maturation of the immune system. Developmentally, we have the problem with the effects of environmental pollutants. A lot of pesticides and other environmental pollutants mimic certain hormones and can damage receptors on cells. Other than that, your endocrine system seems to work pretty well throughout your life. As you age, the anterior pituitary becomes fibrous and a little less vascularized, so there may be a little problem with delivering hormones. We do know that growth hormone declines as you age, and some people have indicated that growth hormone may be responsible for the loss of muscle mass as you age, and while that may play a role, as we age we also tend to be less active, and if you don't use it, you lose it. So it may be a little bit of both. Some people are looking to growth hormone as though it's the fountain of youth. There are structural changes in the adrenal glands, and of course in women the ovaries decline with age and menopause sets in. Aging may alter secretion rates so that you have less hormones secreted. It may alter the rate of the breakdown of the hormone, causing it to be broken down faster or slower. How you excrete the hormone, a lot of that's through the liver and the kidney, and as you get older sometimes those don't work as well. And receptors may become less sensitive, so you may have less affinity between hormone and receptor. Any of these can alter how well a hormone works in your body.